Let's put 3 minutes on the clock. 2 minutes and your time starts now. Hannah Lee, a 45-year-old woman, presents to your GP clinic with a 2-month history of fatigue, weight loss and joint pain. She reports experiencing intermittent fevers and night sweats. Over the past few weeks, she's noticed a rash on her legs, which she describes as red and purplish spots. Hannah has a past medical history of hypertension, for which she takes amlodipine 5mg daily. She has no known allergies, does not smoke, and drinks occasional alcohol. On examination, Hannah appears pale and slightly unwell. Her vital signs are temperature 37.8 degrees, blood pressure of 140/85, heart rate of 88 beats per minute, respiratory rate of 16 breaths per minute, and oxygen saturation of 97% in room air. You note a palpable pruritic rash on her lower legs and mild tenderness in her joints. Question 1.1. What differential diagnoses should be considered based on Hannah's presentation? List 4 differential diagnoses. All right, and time is up. Let's get to some of those answers then. And this is one of those questions there where it can be so many things. So feel free to kind of shoot from the hip and throw out pretty much anything you can think of, because it's probably going to be worth some marks. So the big ticket items, of course, you should be thinking with a presentation like this is going to be an acute vasculitis, and in this case, a Henoch-Schönlein purpura. That's going to give you 3 marks. This could also be, and equal to consider would be, acute infective endocarditis, particularly with that purpuric rash. Now, there is that kind of chronic nature, those night sweats there. This could also be something like myeloma, so it would be high on the list. And even though we have had this medication as a long-term medication, you can have drug eruption rashes at any time. And so another thing you would have to consider. Kind of tying in with the leukemia, and I suspect in reality would probably be grouped together, would be leukemia. And of course, systemic lupus erythematosus, one of the great mimics that can present as just about anything. Rheumatoid arthritis, and this would be a slightly more atypical presentation, particularly with that rash, but something you would have to consider. And then some of your kind of less likely, but things you would kind of keep in the back of the head: deep vein thrombosis, sarcoidosis, tuberculosis, polycythemia vera, and a hemolytic anemia, being rather non-specific, so certainly worth less points here. I think if you're showing that you're thinking along these kinds of trains of thought, you're going to be getting marks, and really this is one of those questions that have so many potential answers, but you can see there's that weighting there towards those ones that show that consultant level finesse. And of course, coming in from the chat here, we've got systemic lupus, fantastic, meningococcosemia. Now, I'm going to be a little bit picky on this one because, yes, if you're looking at that from the acute setting, but this is specifying this has been occurring over the last few weeks. And so if it was something like meningococcal septicemia, this would be a patient that would probably be doing much, much worse, much, much sooner. And so I don't think you would actually get as many marks from that one. Rheumatic fever, yep, definitely, and kind of ties into a lot of these same eruptions there, and drug reaction as you've specified. So very well done on those answers there. Now, of course, we've got more questions to get through. So let's get 2 minutes on the clock, and your time starts now. Question 1.2. What initial investigations would help to further evaluate Hannah's condition? Write 5 specific investigations. All right, time is up. Let's have a look at those answers there. Now, I originally tried to write this one as a multiple choice, but there are so many things you can throw out. So again, thought I'd switch it over and turn it to a response. One of the things, particularly with this time frame, you would be considering would be a tissue biopsy of the lesion. This is going to give you lots of information about the underlying etiology. So that would be very high on the list and worth lots of marks. Of course, you've got your full blood count. You'd be looking at both your platelets, given the nature of the rash, as well as your inflammatory markers, so white cell count, and your red blood cells as well, checking for any evidence of anemia. You're also going to be looking at your ESR, your erythrocyte sedimentation rate, which is going to give you lots of information about the inflammatory state of the body. This is one of those times where your ANCA, your anti-neutrophil cytoplasmic antibodies, will come into play. Your C-reactive protein is, again, inflammatory status. Your complement protein, C3, C4, anti-nuclear antibodies. I know, occasionally we have to actually order that for good reasons. It's one of those tricky ones that will come up all the time. And it's always borderline. Anyway. Rheumatoid factor as well. Cryoglobulins, coagulation studies, and throat swab looking for streptococci or streptococcal antibody titers, as long as you're kind of acknowledging that at risk of streptococcus being the initiating factor. Hepatitis B or C serology, human immunodeficiency virus serology, remembering seroconversion syndrome can do all kinds of weird and wonderful things, and your serum protein electrophoresis or urine protein electrophoresis, again looking for your hematological malignancies. Blood cultures, if we are thinking this could be along that kind of septicemia type picture, and of course, or infective endocarditis, and your urinalysis or urine microscopy culture sensitivities or looking for cast cells. So heaps and heaps of things that you can be throwing out here. This is kind of that looking at your vasculitic screen, your inflammatory screen, your infective endocarditis screen, and malignancy screen as well. Coming in from the chat, we've got FBE, LFT, blood film, which is not on here, but certainly would be part of that full blood examination. If they're actually doing a proper full blood examination, it should be someone looking on a film, but yes, excellent to actually specify that. Coagulation studies, absolutely fantastic, and TFTs. Now, I don't have TFTs on this list, but you are 100% correct. That would definitely be worth marks there, remembering thyroid disease can present with all kinds of weird, wonderful things, one of the great mimics, and so would be applicable here. Well done. And of course here we've got another one, FBC, ESR, ANA, ANCA, blood film. All fantastic answers there. Well done. Now I'm going to be super picky, and again, I know you guys know, I know, but spell stuff out. Try not to use the abbreviations, because remember, there's no guarantee that on the exam day the college or the examiners will actually accept any of those abbreviations. And so if, similar to what, say, Demir's put in here, where essentially it's all the abbreviations, you may have actually just thrown away all the marks except for blood film. It's pedantic, I know. It's frustrating because sometimes we don't know how to spell all these long words, and that's okay as well. They've said, you know, if the spelling's incorrect, that's okay, as long as they can get across what it was you were trying to order, that is fine. So do practice from today, actually spelling everything out. It's frustrating, I know. All right, we have a third question on this case. So let's get 2 minutes on the clock, and your time starts now. Question 1.3. What are potential serious complications of untreated vasculitis? Write 4 specific complications. All right, time is up. Let's have a look at some answers here. So heaps of complications, and of course, these are things that you should be pretty familiar with. So of course, one of the big ones is acute renal failure, pulmonary hemorrhage, myocardial infarction, gastrointestinal perforation, skin ulceration, stroke. All of those things are going to get you 2 marks. They're the big things we really, really worry about. Of course, there's also things like peripheral neuropathy, aneurysm formation, vision loss or blindness, as well as chronic pain and disability. These are things that are certainly important, can have a dramatic impact on a patient's life, but they're not that same immediate life-threateningness, and so would be worth 1 mark. Now, I want to point out as well here that this is one of those times where they actually give away late in the case part of what this diagnosis could be. And this is one of those times as well, if you've been struggling to kind of work out what's going on, this is where reading through the exam first and kind of getting a feel for what each case is about can be really, really helpful. Because if you hadn't picked up that this was a vasculitis, here is your answer sitting in front of you. And so you can actually go back and put that in and make sure that you're getting as many marks as possible. Now, of course, coming into the chat here, we've got from Demir, permanent vision loss, perfect, renal failure, definitely, ischemic heart disease, yes, definitely, and stroke, fantastic, full marks there, well done. And here as well, we've got liver failure, kidney failure, thrombosis, definitely, and myocardial infarction, definitely. Now, I would be a little bit careful, you may get grouping there for thrombosis and myocardial infarction, because myocardial infarction may be part of that thrombosis picture. So similar etiology. I mean, you can have multiple things contribute to a myocardial infarction in the setting of a vasculitis. Wow, try saying that 10 times fast. So I would just try and diversify those answers ever so slightly, just again to make sure you get the best chance of getting as many marks as possible. But all very good things to be keeping in mind, so well done. All right, now of course, let's get on to the next case then. So case number 2. Oh, and of course I want to acknowledge for that last case there. Thank you, DermNet. And if you're not someone who actually goes through and has a look through the DermNet photos, again, given we don't have that much time before the exam, now is actually a really good time to do it. Keep them fresh in your mind because most of the derm or skin kind of questions are going to come from DermNet. There is a fantastic library on DermNet that you can actually just step through, have a look at the pictures, have a quick read of the condition that's involved. They have fantastic summary articles that if you are time poor, you can just kind of have a read through and just try and get a feel for a couple of the big kind of ticket areas and just read up, refresh your knowledge. Okay, so a comment in here from the chat as well, not a topic I know much about, and yeah, this is one of those cases that I think it's easy to miss in your kind of internship HMO years. A lot of medical schools don't have vasculitis as a kind of significant R1 topic if you've gone through the Monash model. And so it's one of those things that I think if you haven't actually seen a patient with it, this one could be one of those cases you don't do as well in. Which is again why we do these practices here to try and identify areas that you may need to do a bit of reading up on. And so if it's something you're not feeling that very confident in, do a quick read up. DermNet, the College of Pathology, and RACGP, if you just do Google for RACGP vasculitis, you're going to find a heap of really good articles written for the GP knowledge base.